Hello, my name is Lori Thompson. I am a clinical nurse educator at Alberta Hospital Edmonton, and I'm here to do a presentation on recovery-oriented care. This video is part one of two. The first part should take about 30 minutes, and I'm going to talk about recovery-oriented care. A disclaimer, as educators, we facilitate learning, but we are definitely not the experts. Luckily for you, you are in a virtual room of experts. The sum total of the experience and knowledge of our addiction and mental health staff is astounding. I hope that this session will stimulate a zest for learning about more on the topic. And if you do have further questions, please feel free to contact me. My phone number and email address are listed there. So what I'm hoping to cover today is what is meant by the term recovery-oriented care. Also, how to speak and think in recovery-oriented language and how to apply this to your patient population. After this session, we are hoping to have other presenters who will talk to you about how to take this theoretical information and the care plan I'm going to talk about and put it into your Connect Care treatment planning. So what is recovery-oriented care? It is supporting the person you are working with to find a life beyond illness. This means working collaboratively with the person to develop a shared care plan. It's influenced by personality and values. It is unique and forward-looking, although it may involve the past. It is based on what the person actively wants. The care plan always requires the client to take personal responsibility and put in some effort. The principles of recovery-oriented care are using the strengths of the client, and it looks at the client holistically. It supports the client in their life beyond their illness and treats the client as the expert in their own life. As the care we provide ultimately must be accepted and agreed upon with the client, our care plan will be more successful if we look at the strengths the client already has and treat them as the expert in their own life. So what is the definition for recovery-oriented care? The definition is recovery from mental disorders and substance use disorders is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Let's take a closer look at that definition. If we omit the words all the way up to disorders and just say, it is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. We can see that there's not much difference between clients and staff. Isn't this what all human beings are trying to do with their lives? Our job as clinicians is to assist our clients in achieving this. There is a lot of research out there that shows that when people with mental health or substance abuse issues have something meaningful to do, they will have better outcomes. Supporting a patient to make their own decisions to reach their full potential is much more effective than determining their potential for them. As the saying goes, you can lead a horse to water, but you can't make them drink. I like the picture in the corner because it reminds me that we are in for a fight if we try to force a client into a plan that they don't agree with. So imagine for yourself that AHS wants all of their staff to be healthy. That's a great goal. And AHS has determined how to achieve this goal. All AHS staff must get 8 hours of sleep every day, drink 2 liters of water, no alcohol, and no fast food. This plan definitely will make AHS staff healthier, right? But how many staff will actually follow that plan? This is not a recovery plan. A recovery plan would be for AHS to ask all of their staff how they would like to become healthier and then support those individuals in their plan. Recovery is a process. As a patient goes through the recovery process, the illness circle will become smaller. Family, work, peers, and interests will then take up more room. When a person is in a mental health crisis, their illness may be the only reality that they see right now. Recovery is a constant process. Mental illness is a constant process for recovery. So how can we help a client through recovery? One way is by using a tool where the caregiver can support a client in achieving their goals. Any tool that has a recovery care focus can work. Using a tool helps us to help the client stay on their path of recovery. It helps them to see their goals of recovery and the work that it takes to get there. As a client readjusts this tool based on their current state, they can see where they have been and where they are hoping to head. The recovery care planning tool that you see in the picture is only one of many tools. Any tool can work by keeping the recovery-oriented care principles in focus, namely that strength-based, holistic support and treating the client as an expert. This tool should be completed by the patient. They should write out what their hopes, what their dreams are in their own words. The clinician, or you, would then assist them in coming up with what their strengths and their needs are. Once this is completed, you would work with the client to come up with their short-term and their long-term goals to meet their ultimate goal. For example, if their top goal is to become fit, you can break that down into goals for exercise, goals for healthy eating, goals for adequate sleep, etc. The important components of the plan is that it is in the patient's own words or handwriting, and possibly it has in their own handwriting if possible, and has a clear outline of the plan and the dates the goal will be completed. Notice at the bottom of the picture there is a copy should be given to the client box. It is important that a patient gets a copy of this care plan so that they can follow along. Here is another tool. There isn't one right way to complete a recovery care plan. It's more about the consistent use of the client's goals and supporting them to achieve these goals. There's multiple ways to do this. These slides just show two examples of the tools that can be used to have a recovery conversation with your client, but it's more about the mindset of the clinician to ensure that our focus is always on the client's goals. This first tool was quite structured, while this one is less structured and just facilitates a conversation with the client. The Thought Bubble Care Plan is also useful for clients with lower cognitive abilities or someone who's not yet ready to make a change. So now it's your turn. In your package, you would have received a care plan that looks like this. In the bottom left-hand corner. And what I would like you to do is over the next few slides, we're going to create a recovery care plan for you. I want you to think about what goals you have in your life, and over the next few slides, we will complete your care plan. So for the first step, I want you to fill in your hope or your goals or one goal that you have right now for your life. Then I want you to write in what you feel your strengths are, and then I want you to take a look at what your needs are to achieve that particular goal. Once you have completed this, you're going to break those goals into parts that are required to achieve it. Things to remember as you're filling this out is you can include short or medium or long-term goals. You can use the readiness ruler that is on the tool to indicate how prepared you are to make those changes. The goal should come from you, so you should be writing it in your own words. And then you can break that goal into manageable pieces. The goal that is written if you are working with a client should come from the client's own words and in their own handwriting if possible. And the goals can be inclusive of anything that affects their life. So for example, my ultimate goal would be to become healthier. My strengths are that I like to walk and play soccer and I like to cook. My needs are that I don't know of any soccer clubs for my age and I don't know how to cook healthy meals. So when we drill down, my first goal is to buy a cookbook on healthy meal prep. The staff support that I need is to help me to shop for a book, and at this point staff can discuss other options such as internet recipes or a cooking class. Later in the presentation, we're going to be discussing some of the stages of change as well as motivational wording that would help a client create these goals and move through those stages of change. In step one, it's the clinical staff responsibility to ensure that the goals are realistic. So a nice framework to use is the acronym SMART. to help the client set their goals. SMART can be used by the caregiver to set their own personal goals with the client as well. So when we think about SMART, S stands for specific. What exactly do you want to achieve? M stands for measurable. How will you know when you've achieved it? A stands for attainable. Is it something you have control over? R stands for relevant. Why is this applicable to your life? And T stands for time-based. When do you want to achieve your goal? If you need some time to complete your recovery-oriented care, just pause the video at this point and restart it when you're ready to move forward. So putting the information together, my recovery-oriented care plan would look like this. Using a tool helps us help the client stay on their path of recovery, and it helps them see their goals of recovery and the work it takes to get there. As a client readjusts this tool, they can see where they've been and where they're hoping to head. So you can see my goals, you can see my strengths and what my needs are. I've written the date of when I completed this, what my particular breakdown goals are, and how willing I am to work on those particular goals. The staff support that I require to complete these goals are listed here, and I have a date of when I hope these goals would be completed. If this was being completed between yourself and me, you would check this off and you would give me a copy, and a copy would go into my documentation. So step 2, how do we support this recovery? So our approach is really essential to ensure that we are having a recovery approach. When using the care plan, in the traditional approach, we would always reward a patient that followed the rules and the norms of the clinical team. We had set care plans that we would fit our clients into rather than the other way around, sort of like a square peg into a round hole. The traditional approach focuses on the disorder. It is illness-based. It rewards passivity and compliance. It is based on reducing the adverse effects. With recovery, we see the client as the expert of their own life, and we change the care plan to meet the needs of the client. The recovery approach is focused on understanding, focusing on the person, looking at the strengths that the particular person has, and basing our care plan on those strengths, fostering empowerment so they are doing the work, and based on the hopes and dreams so we get the buy-in from the client. So does this mean that we don't do a clinical care plan anymore, that we only do a recovery care plan? No. But we incorporate the client's goals into the clinical care plan in order to get traction to move forward. So what we need to do is look at the commonalities that are between what the client wants and what the care team thinks is beneficial for that client. We're going to use the client's goals for engagement, and if we use their goals, that may help us change their behaviors. And it also helps us explore the reasons behind what the client's goals are. We had a patient at the hospital who really did not want to take his medications, and it was a fight each time he needed to have his medications. He refused medications continually, and it was very difficult to get the medications into him. When we talked to this patient about what his goals were, for a big part of this client's life was his family, and he was very invested in ensuring that his family was happy for him and that he was meeting the expectations that his family had. And his family really wanted him to take medications. So by using that goal of the client trying to please his family and maintain relationships with his family, we were then able to use that motivation to help change his behavior in his medications. So that's how you can see how we pair the clinical care plan with the recovery care plan. The third step is collaboration. Clients and caregivers sign the recovery care plan and agree to partner to help the client on their journey of recovery and well-being. The client, of course, gets the copy of the plan to ensure that they feel that their views of what they need are reflected. And they have had a say in what was written. The recovery care plan is portable, and it should follow the patient in all of their transitions. Any care team meetings, any transitions or transfers, the care plan should follow that client. And lastly, this care plan should be reviewed often. These plans are the strengths-based and orientated towards reinforcing a positive identity and developing those valued social roles. And when your client hesitates, refuses, or is reluctant, remind them of their goals, and you may need to support the patient to adjust their plan. The client needs to get a copy of this, and this plan should be reviewed through every part of the journey. So the care plan that I provided about me, the becoming healthy, was fairly easy. I was focused on healthy goals, and I seemed to be very motivated to achieve them. But often our clients' goals may not match the goals of the clinical team, and that's okay. When you think about your own life goals, do they match those of your physician, of your family, of health itself? If the goal that the client comes up with does not match the clinical teams, or does not seem to be realistic, or does not seem to be healthy, this then becomes a great opportunity to explore why. We had a patient here at Alberta Hospital who wrote that he wanted to fly to the moon. And the staff tried to work with this, knowing that the odds of this particular patient flying to the moon, or any of us, were astronomical. But if the patient's goal was space travel, then our staff could use this to improve other areas of his life. So for example, for hygiene, who wants to go in a tiny rocket with someone that smells? Or to improve attendance to some of the patient programs that we have. We know that attendance to all training is really important for astronauts. Or to improve desire for higher education. We know that astronauts need to have lots of education. So we could use this as motivation to get the patient to follow the clinical team's plans. This did help the patient with the motivation, but at that point we thought, well, what happens when this patient is now clean as a whistle, he attends all the programs, he gets higher education, but he still can't fly to the moon? This patient would then feel that the staff have lied to him or tricked him into doing something when we knew that his plan was unrealistic. So instead of using unrealistic things that the patient comes up with, it's better to explore the reasons why that person has that unrealistic expectation or goal. So for this particular patient, we wanted to explore the reasons of why he wanted to fly to the moon. So the reason that he told us was he wanted to be as far away from Alberta Hospital as possible, and for him, in his mind, that was the moon. So we changed the goal to getting discharged from Alberta Hospital, and that was equated to his goal of flying to the moon. So maybe you have a patient who their goal is to stop medication. We need to explore the reason why. Does the patient hate swallowing pills? Can we switch to a depot medication? Or do they hate needles? Can we switch to a pill? Is there a side effect that we can help them with? Is the medication not working, and could we switch to something else? Is there some type of a knowledge deficit and we can provide some information? Or maybe we have a patient whose goal is to do a lot of drugs. Is this because the patient wants to blank out because they can't cope with something? Does the client have some trauma to work through? Are there some cravings that we can help them cope with? Or are there some harm reduction strategies that we can use to decrease the risk of them continuing to smoke a lot of pot? Another limitation with recovery-oriented care is related to delusional beliefs. So what if the patient has a goal and it's a delusion, like becoming a famous rapper or having the power of invisibility? This is where our clinical judgment comes into action. we need to explore the reason for the goal. Is there something else going on? Do they want to be a famous rapper because they like singing, or they just want to be noticed, or is it they want to be rich? We want to discuss the facts of the goal. Are there some statistics and facts? And we do need to be careful. We don't want to be lecturing our clients about statistics and facts, but are there statistics and facts that we can bring up in a gentle way? If invisibility doesn't exist, how do they plan to achieve it? Also, we want to provide appropriate treatments if able. If the patient is delusional or psychotic, now may not be the time for a recovery-oriented care plan. It may be more important to provide treatment first before we could work on a recovery-oriented care plan. But that doesn't mean that we lose the recovery-oriented care out of our plan of care for the patient. I also want to point out that some goals that we feel are unattainable might not be if the patient is really motivated. The picture on the screen is Patricia Deegan. She is a disability rights advocate. She's a psychologist and a researcher. She was diagnosed with schizophrenia in her teens, and her family was told that they should admit her to a mental health institute where she would live out her life. But Pat had a goal of becoming a psychologist and going on to ensure the world knew that she was a person and not an illness. Today, Pat is an international speaker and highly regarded for her work in helping people with mental illness. I highly recommend watching any of her videos on YouTube. So if there's any questions on recovery-oriented care, my name, phone number, and email is on the front of this presentation. Please feel free to reach out to me. The next thing that we're going to be talking about is recovery-oriented language. Not only do we need to look at the strengths and goals of our patients, but we need to use language that instills hope, positivity, and client-centered strength. Words are important. The language that we use, the stories we tell, all have great significance to everyone that is involved. They carry a sense of hope and possibility, or they can be associated with a sense of pessimism and low expectations, both of which can influence the personal outcomes. It's not just our words, but also our nonverbal communication. When we are thinking words that are negative, our nonverbal communication can indicate that. So what does this quote from Mother Teresa say to you? I was once asked why I don't participate in anti-war demonstrations. I said that I will never do that, but as soon as you have a pro-peace rally, I'll be there. So close your eyes, and what pictures do you see in your mind when I say the word anti-war? And what picture do you see in your mind when I say the word pro-peace? Though these are the same concepts, the language can instill negative or positive thoughts. The words that we choose reflect our attitudes, that we do or that we do not truly value people. It also shows that we believe in and genuinely respect them. Our language should represent what we mean. It should reflect unconditional positive regard for people, be free of any jargon or confusing data. It should carry a sense of commitment, hope, and presents the potential for opportunity. We may be unaware of the impact our words have on our attitudes, as well as the words that we say, how they impact those people that are around us. I really like the before you speak, think acronym. Is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? Because our language is read or heard by the person whom we are referring to, we want to know how they see the language that we're using. Does our language positively contribute to their health and well-being? And when we think of the rule, do unto others as you would have done unto you, it's a nice sentiment, but it doesn't have a place in recovery-oriented care. What works for you may not work for someone else. So for example, when you meet someone for the first time, you may appreciate a nice strong handshake. Someone who has been physically abused may have a difficult time with physical contact. So in recovery-oriented care and trauma-informed care, we ask that the patient or client, we ask them what works for them, not for us. The language we use makes a difference to the way we think as well as to the way our clients perceive us. When we think of some of the worn out words that most of us have probably been trained in and are used to saying, Sam is mentally ill, Sam is schizophrenic. We need to change that thinking and the way that we speak our words and the way we think our words for language to be of acceptance, to be hopeful, respectful, and look at the uniqueness of each of our clients. So instead of saying Sam is mentally ill, we would want to say Sam lives with mental illness. Instead of saying Sam is a user, we would want to say Sam uses methamphetamine. Instead of saying Kylie committed suicide, Kylie died by suicide. And I get trapped in these quite a bit. You're so used to using these words that it just comes out, and you don't mean, or I don't mean to be negative when I'm saying them. It's almost like speaking an addiction and mental health language. We need to frame our outside words, the verbal words that we're using, and our internal verbiage that we're using with this language of acceptance. So think about some of the words that we use on an everyday basis, like addict, user, drug seeking, manipulative, needy. When you think of those words, it brings a connotation of negativity to your verbal and your nonverbal communication. So when we think of the word manipulative, is there another word we could replace it with that means the same thing? And for myself, for manipulative, I would use the word resourceful. Or what about the word needy? Is there something else we could replace that with? Doing something like maybe able to make needs known. We can go through a whole list of words that we use that have negative connotations, and we should be looking at ways to turn that positive. If we say that our patient is unrealistic, we could say instead that the patient has high expectations. Instead of saying that this person is in denial, we could say that this person disagrees with their diagnosis. Think of other words that you use in your everyday language, and not just yourself, but your colleagues around you. Is there a way that you could reframe those words into something positive? The next section that we're going to take a look at is change theory. Change is a process. Recovery is fundamentally about the motivation to change. At some point in every person's life, there comes a moment when they realize they need to change. The difference between those who successfully make the needed changes and those who do not comes down to motivation. Since motivation is so critical to recovery, it's important for us to understand the motivation for change. This includes understanding the degree of motivation, the type of motivation, as well as understanding various ways to increase motivation. Once sufficiently motivated, people can and do change. Like my story of the gentleman who did not want to take his medications until his family, until we used the desire for his family to have him take medication and his desire to please his family, that motivated him to make a change. But not only does change affect our client, it affects us as caregivers because we may need to change our approach to be more in line with recovery or more in line with where the patient wants to take their goals rather than that traditional medical model. Anyone who has ever made and broken a New Year's resolution, like myself, can appreciate the difficulty of behavior change. Making a lasting change in behavior is rarely a simple process, and it usually involves a substantial commitment of time, effort, and emotion. Whether you want to lose weight, stop smoking, or accomplish another goal, there is no single solution that works for everyone. You may have to try several different techniques, often through a process of trial and error, in order to achieve your goal. The Stages of Change model by Prochaska and Di Clemente help us to understand the change process. The model demonstrates that change is rarely easy and often requires a gradual progression of small steps towards a larger goal. Understanding the elements of change will help you support your clients to achieve their goals. As much as we would like to believe that everyone with an addiction is ready and motivated to stop using drugs or take their medication. In reality, most people are in different stages of change. According to Stats Canada, the Canadian Tobacco and Alcohol and Drug Survey done in 2015, an average of 45% were in the maintenance stage, 21% of smokers were in the pre-contemplative stage, 18% were in the contemplative stage, and 12% were in the preparation phase. That left only 1.4% of smokers identified as being in the action stage. So when we are assessing our patients, we need to determine the stage of change that they're in. And as they move through the stages, you can see this center upward spiral. Every time a patient relapses, they learn from that relapse. And how can we use that learning to get them back on this cycle of change? Another issue that we have is reaching patients when they're in the pre-contemplative stage. How do we reach those patients who are not even contemplating change? Motivational interviewing is a way to help people move through change, though it is very ineffective in pre-contemplation. It's more effective as we move closer or move further through the cycles of change. So how many attempts might a patient need before they change a behavior? Think about a smoker who has quit for 10 years. Do you think they have cravings? Might a stressful situation cause them to restart? We know that there needs to be a lot of attempts before a change in behavior happens. It typically does not happen on the first attempt. But when we're trying to affect change, we need to self-reflect ourselves. Are we using the recovery-oriented care principles, or are we trying to change the patient to fit their square peg into our round hole? Also, we need to look at our goals versus their goals, and what are the commonalities between how can we work together and gain trust with our clients by using their desires for their changes and their goals and our desires for their changes and goals. And oftentimes we do not know what the outcome is going to be. In our conversations with clients, we're laying some of the seeds. We may only be at the first part of the laying of seeds, and we may never be there when they achieve their goals. But we know that without that laying of seeds, they are never going to get to the part where they have made changes. So I say this to hopefully instill in you not to give up hope when you are trying to help a patient and you yourself are not seeing any changes. Oftentimes those changes are small and internal for the client, and it may not be something that you're going to see right away. So how do we use this to motivate clients to work on change? In your package, you were given a piece of paper with this on there. I would recommend that you spend some time and take a look at this on your own time. You can see that it talks about each of the stages of change and the different techniques that a clinician can use to try to move the client further through the different stages of change so that we get to the golden stage, which is maintenance. But let's look at one more tool in our toolkit, motivational interviewing. So the principles of motivational interviewing, and you received this in your package as well, were discussed with you in a training that you hopefully have received from Marcia Bueller. If you haven't received training on motivational interviewing, I would highly recommend that you do. I've put this slide in here just to remind you of some of the information that she provided for you related to the principles and tools of motivational interviewing. Motivational interviewing is a set of skills that assists a clinician in evoking change. It's meant to diffuse feelings of distrust and defensiveness, and that is often caused by unsolicited lecturing and by shifting the power to the learner instead of from the lecturer. Some of the main principles in motivational interviewing are listed on the screen here. ORS stands for open-ended questions, affirmation, reflective listening, and summarizing. have a 5-minute video for you on motivational interviewing. I cannot play it on this recording, so you will have to pause the recording and type this into your web browser or click on the link, and you should be able to find the video, How to Change People Who Don't Want to Change. Watch this 5-minute video and then come back to this recording. So finally, I want you to take time to think of an unhealthy habit that you may have now or you have had in the past. Some examples might be smoking or eating unhealthy, not exercising. When you think of the video clip you just saw, what would have worked better for you, lecturing or questioning, and why? When you think of getting unsolicited advice, what kind of feelings does that bring up for you? And does that work for you to elicit change? And I also want you to consider the power balance. In a lecturing situation, who has the power? And who has the power in a questioning situation? For someone who's ambivalent about their change, unsolicited advice may suggest that the person needs something from the advice giver. This implication by the lecturer may cause resentment and frustration by the learner. In fact, listening to the advice may be considered more therapeutic to the lecturer, who may want to feel more powerful and knowledgeable. Lecturing may also come across to us as one-upmanship or assertion of dominance, or criticism or distrust, or failure to consider our own unique goals and priorities. A questioning approach will allow the learner to explore their own thoughts on the subject. So this ends part 1. I would encourage you now to watch part 2, where we will take all of this theoretical knowledge and put it into a case study. Thank you for listening.